Hello, and thank you so much for joining us today for the webinar Recession Coverage New Regenerative Materials. It is a great pleasure to introduce to you Dr. Adrain Kasaj, whose aim during this presentation will be to review and discuss the various soft tissue grafting techniques and the expanding role of 3D collagen matrices in the treatment of single and multiple gingival recessions. Dr. Adrain Kasaj graduated the School of Dental Medicine in 2000. 1 year later, he became a dentist in a private practice in Neustadt-Weinstraße, Germany, and finished his doctorate at the Department of Operative Dentistry and Periodontology at the University of Mainz. Between 2001 and 2009, he worked as a research associate at the Department of Operative Dentistry and Periodontology at the University of Mainz. During this period, Dr. Kasaj finished his postgraduate education in periodontology at the Department of Operative Dentistry and Periodontology at the University of Mainz and became a specialist in periodontology of the German Society of Periodontology and the European Dental Association. He is an author and co-author of more than 80 scientific publications within the field of periodontology, numerous national and international courses and lectures in the fields of regenerative periodontal therapy and plastic periodontal surgery. We would like to thank Dr. Kasaj for being with us today and botiss for making this lecture be possible here. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Kasaj at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Adrain Kasaj.
So, good evening to everybody. Thank you for joining us on this live webinar on root recession coverage. There's the possibility that you have some delay of the camera due to the internet connection. So when we are talking about gingival recession, you should know that they might occur on single root surfaces as well as on multiple root surfaces. They are often associated with some aesthetic concerns, root hypersensitivity, as well as with the problem in optimal plaque control. If we ask ourselves how often are these gingival recession occurring, we might look at a study which was published 2010 by Safatia, looking at more than 2,000 subjects. It was a cross-sectional study design, and the statistical unit was the patient. And what they could observe was that most of our patients exhibit at least one gingival recession. But most of them have a gingival recession depth of between 1 to 3 millimeters. So the deep and severe gingival recessions, like equal or more than 6 millimeters, were very seldom. Another point of this study was that they found that most of the recessions occurring were Miller classes 1 and 2, much more frequently than Miller classes 3 and 4. And so we can conclude that the slight gingival recessions are very common and that the severe gingival recessions are rare. So with respect to the etiology of gingival recession, I'm not going to go in detail on this, but just to be complete, we have the predisposing pathogenetic factors, including the bone dehiscencies. We know that the gingival phenotype is important. You can see here in the upper picture a very thin gingival biotype with the roots shining through the alveolar mucosa compared to a very thick gingival biotype in this picture. We know also that the apparent frenal attachments are considered predisposing pathogenetic factors, and we have the causative pathogenetic factors, including or number one, traumatic toothbrushing technique, inflammation. We know that orthodontic movement is an important causative pathogenetic factor, and an iatrogenic factor would be subgingival crown margin position. Another factor which we didn't know a couple of years ago are the piercings as a traumatic factor. What we can see in conjunction with these piercings are infraction of the tooth substance, but also we can see infractions to the soft tissue. So piercings are today considered as an important traumatic factor in the etiology of gingival recession. So when we are talking about diagnostics, a lot of classification schemes have been advocated through the years. The one which is still used most is the Miller classification, and it's not only for diagnostic purposes, but it's also to determine the amount of root coverage which is achievable. So we know that in Miller classes 1 and 2, we can anticipate a complete root coverage, whereas in the class 3, only a partial root coverage is anticipated. And we all know that the Miller class 4, there's no root coverage anticipated, so we have to go for another approach, like, for example, extraction, or as in this case, the preparation of a silicone gingival epithesis. Some more modern approaches for gingival diagnostic include the use of 3D optical scanning systems. This was a publication of our group from 2012 using optical scanning for quantification of soft tissue dehiscencies. So you can see here gingival recession, and here the scanning to quantify the amount of soft tissue lost in this area. So this kind of technique we can probably also use for treatment planning to show our patients, okay, this is the amount of soft tissue which has been lost, and here to explain the patient the process of soft tissue grafting. So this would be a connective tissue graft. And we might also use these systems, for example, for a case like this. So this would be the baseline clinical situation. This is the results we want to achieve. And perhaps in the future, we are going to scan the soft tissue lost. We are going to measure the amount of soft tissue which is missing. And then we might get some soft tissue out of the box, so a customized soft tissue ready to be transplanted during the surgery. So with concerning surgical techniques, a lot of techniques have been described during the decades, and in the 30s the frenectomies were firstly performed. Then after World War II, the gingivoplasty by Goldman was introduced. The laterally positioned flap was introduced in 1956. The apical repositioned flap in 62 and 63. The free gingival graft was introduced. And in the late 90s, the American Academy of Periodontology changed the term of mucogingival surgery into periodontal plastic surgery. If we go to the literature, we can find also some techniques which were even described decades before. For example, here, a technique which was proposed by Paul Rosenthal already in 1912, and this was published in Dental Cosmos. So more than 100 years before, we can see first procedures for coverage of exposed root surfaces. So if we go to modern periodontal plastic surgery, we might divide all these techniques into 3 groups. So we have one group of the pedicle soft tissue grafts, where we would include the coronally positioned flap, the laterally positioned flap, and some techniques we don't perform on a regular basis, like the double papilla flap or the semilunar flap. Then we have the group of the free soft tissue grafts, which would include the free gingival grafts. the connective tissue graft in conjunction with pedicle soft tissue flap, and we have the modern minimal invasive envelope techniques. And the third group would be the group of the additive treatments, where we would include the root surface modifiers, guided tissue regenerations, the use of animal matrix derivative, all the dermal matrices, and also PRP, PRF, which would be additive treatment. So if we take a closer look at the pedicle soft tissue grafts, the one which is mostly performed is the coronally position flap. So we do a full thickness flap, we create some surgical papilla, we de-epithelize the anatomical papilla, and we position this flap after releasing it into a coronal position. The lateral position flap, much more difficult to perform, and the double papilla flap or the semilunar flap are rather seldom used and not really necessary for daily clinical practice. Today we are dealing much with free soft tissue grafts, and here, for example, we have an envelope technique with connective tissue graft. So you see the preparation of an envelope, harvesting of the connective tissue graft, and inserting this graft into this pouch. So where did we start? In the 60s and 70s, a lot of free gingival grafts were performed. So the focus was on augmenting the width and later also the thickness of keratinized tissue. So this was based on a study by Lang and Le, suggesting that a minimal amount of 2 millimeters of keratinized tissue is necessary for periodontal health. So this is what was performed. First, augmenting the zone of keratinized tissue, and you can see here the aesthetic appearance was very poor, but this was not the focus of this procedure. And this was secondarily performed a coronally positioned flap. And again, if we would judge this by some aesthetic score, which we use today, we see that regarding the texture and the color, this is not an optimal outcome because it doesn't integrate well into the surrounding tissue. And what you can see is this, what we call an entire patch appearance. So over the decades, we switch more to aesthetic, to the aim of root coverage, and in the mid-80s, to be exact, in 85, the connective tissue graft was introduced in conjunction with the coronally positioned flap. So you can see here clinical case, multiple recessions in the upper jaw. You can see these cervical lesions, and the performance of a coronally positioned flap, so the preparation of split thickness flap, harvesting of connective tissue graft from the palate, suturing these grafts to the periosteum, positioning this flap to the coronally. You can see the healing period, which is here 10 days post-operative, and the final outcome 12 months post-operative. So what we can see on one side is the coverage of the exposed root surfaces. We can see a nice amount of keratinized tissue, but we can also see a nice volume which we gained. So after this procedure, the question was if we can substitute this with something. The question about growth factors came up, and this is from my colleague Marco Del Corso, dealing with growth factors from PRF, from platelet-rich fibrin. Here a case in conjunction with the coronally positioned flap. So it is only the use of the PRF with a coronally positioned flap when you can see a nice clinical outcome 6 months post-operative as a possible substitute for a connective tissue graft. So the next evolution was on the surgical techniques themselves. So the switch to the more minimal invasive techniques. So the first one was the envelope technique, which was proposed by Professor Retzky in 1985, a clinical case showing a deep single recession as a consequence of orthodontic therapy. And you can see the harvesting of a connective tissue graft from the distal aspect of the palate and inserting this connective tissue into the prepared pouch. So what you can see 10 weeks post-operative is a nice amount of root coverage, nice amount of keratinized tissue, also thickening of the tissue in this area. From the envelope technique, the next step was to go to prepare multiple envelopes. So the tunnel technique was introduced. After that, the modification of the tunnel technique. And so this would be like where we are actually now. Again, a clinical case on the modified tunnel technique. You can see here the mucogingival liner. Minimal amount of keratinized tissue left in this area. And you can see the preparation of tunnel, harvesting of connective tissue, inserting this into the tunnel, positioning the whole complex to the coronally, and you can see the clinical outcome 3 months post-operative. So if we take a closer look at this case, we can see, okay, we have a nice amount of root coverage. We have also some thickening of the tissue, but not all the area where the connective tissue graft was inserted is keratinized. So we can see here that the apical portion of the connective tissue inserted here didn't influence the appearance of the covering tissue. Okay, let's go to another case. Multiple recession in the lower anterior area. You see a very thin gingival biotype. The roots are shining through this thin tissue. And again, the same procedure, tunneling the whole area, harvesting connective tissue grafts from the palate, inserting it into this tunnel, positioning the whole complex to the coronally, and you can see here the amount of connective tissue inserted here in this area. Post-operative 3 months, you can see that we have some nice coverage of the root surface, but again, not all the area of the connective tissue graft which was inserted here resulted in the gain of keratinized tissue. So where do we gain the keratinized tissue when dealing with autogenous grafts? It's associated mostly with leaving the keratinized tissue exposed. So if we take a closer look on another case, again, the same procedure, tunneling the whole complex, harvesting the connective tissue graft, inserting it into the tunnel, and now you can see the amount of connective tissue which was left exposed. Again, here the amount of connective tissue which was exposed during the surgery, and here this is the during the healing period, and this is 3 months post-operative. You can see here that the gain of keratinized tissue, nice color of keratinized tissue, is here attributed to the exposed part of the connective tissue graft. Here beneath you can see dense connective tissue but covered with alveolar mucosa. So let's summarize the results following root coverage with the autogenous grafts. If we take a closer look to the literature, we can see a lot of systematic reviews dealing with treatment of gingival recession with autogenous grafts. So all of these studies are systematic reviews, and there are even more of them. And if we draw the main conclusions from all this study, we can say that all periodontal plastic procedures which aim at coronally positioning the flap show the percentage of root coverage above 80%. We can also conclude that the coronally advanced flap with connective tissue graft appears consistently effective in relation to all clinical efficiency endpoints. So if we take a look at complete root coverage, recession reduction, gain of keratinized tissue, clinical attachment level gain, long-term maintenance of root coverage, the best results are achieved with the coronally advanced flap in conjunction with connective tissue graft. We have data showing that the EMD improves the efficiency of coronally advanced flap alone. It seems that the multiple combinations do not provide much better results than the more simpler ones. So if we take a look at the connective tissue graft plus animal matrix derivative plus coronally advanced flap, it doesn't result in better clinical outcomes when compared, for example, to the connective tissue graft with the coronally advanced flap alone. There also seems to be no adjunctive effects by using root surface modifiers, like, for example, the use of EDTA, tetracycline, citric acid. There's no adjunctive effect for this. And as yet, there's no standardized evaluation of aesthetic satisfaction. So we can conclude at this point that the connective tissue graft is the gold standard in root recession coverage. So now the question is, do we have some alternatives to these autogenous grafts? So it would be nicer to avoid harvesting of connective tissue from the palate, and also to avoid the post-operative patient morbidity. So in this context, the use of human acellular dermal matrix, the Alloderm, was the first step in this direction. So what is the Alloderm? It is human dermis derived of human cadavers. So the epidermis is removed, the subcutis is removed, and what we get after processing this dermis is 3D collagen matrix, also having some elastic fibers. And so if we summarize the evidence for the use of Alloderm in periodontal plastic surgery, we can see we don't have the literature that we have for the autogenous grafts. So we have only one systematic review, this one of Gapsky in 2005, dealing only with Alloderm for root coverage. Moslemi, one long-term study, 5 years. This is also a single randomized controlled clinical trial, and Harris was a practice-based study, a retrospective study. So if we summarize the evidence on Alloderm, it seems that the Alloderm doesn't provide a significant benefit compared to the coronally advanced flap alone. In the meta-analysis of Gapsky, there was no significant difference compared to the coronally advanced flap with a connective tissue graft. But also a conclusion of this meta-analysis was that it's difficult to draw anything other than tentative conclusions. So not enough evidence for Alloderm in root coverage procedures as yet. The one long-term study of 5 years of Moslemi showed no significant differences between Alloderm and connective tissue grafts. On the other hand, the retrospective study by Harris showed that after 4 years, Alloderm showed only a mean root coverage of 65.8%. So there was a drop down between 1 year and 4 years for the Alloderm group, whereas the group with the connective tissue grafts remained stable. And another thing we should be aware of is that there's no induction of keratinization, so there is no biological information to the tissue covering this acellular dermal matrix. So what is the problem with Alloderm? It's that it's not available in the European countries. It's probably also not going to be available in the near future. So for us, the dermal matrices of porcine origin are getting more and more in the focus and getting also more interesting. So it is similar to the Alloderm. It's also a dermal matrix, but it is of porcine origin. And the one I gained most experience with is the Mucoderm matrix from botiss dental from Berlin. So what is it? It is non-immunogenic 3D collagen matrix. You can see here the structure of this dermal matrix, and if we take a closer look, so this would be a rather smooth surface. If we go inside, you can see this matrix, which is intact, and this is the structure where my fibroblasts, my blood vessels, also the epithelium, should ingrow and repopulate the area, allowing the modeling of new fully functional soft tissue. So if we take a look at the structure of this, so this is the Mucoderm dermal matrix in comparison, for example, to the mucograft or the Dynamatrix, which are no dermal grafts. So here we are dealing with some soft tissue matrices, but this is no dermal graft. So these are membranes, okay, and this is a real dermal graft. So the first study which we performed was to look at the biocompatibility of this dermal graft. We also looked at the revascularization of this dermal graft, and you can see after subcutaneous implantation of the Mucoderm, the revascularization after 3 weeks. So this is a nice revascularization of this Mucoderm matrix. So if we compare this to the autogenous grafts, in an autogenous graft, in a bilaminar technique, you can expect a full revascularization following 14 days. So it seems logical that this is a little bit more prolonged in the acellular avascular dermal matrices. So the next thing we looked at, which we were interested in, was about the rehydration protocol. So the rehydration protocol was not really evidence-based. It was more based on some clinical experiences. So we looked at the different rehydration time here in sterile saline and here in autogenous blood. And then we have put this matrix inside this tensile strength machine, and we looked how much can we stretch these matrices before they tear apart. So interesting results we got here. So it seems that the rehydration in saline solution seems to be best after 10 minutes. And what we saw that there was differences between rehydration in sterile saline and in blood. But it was only differences for the mucoderm, for the dermal matrix. So the dermal matrix was, the mechanical properties were influenced by rehydration with blood, whereas this blood rehydration didn't influence the biomechanical properties of the membranes. So the biomechanical properties seems to be better in the dermal matrix after rehydration in blood. So let's go to the clinical and possible indications for use. So clinical case, you can see after implant insertion, there was no amount of keratinized mucosa left in this area. This was after we applied some Schiller's iodine solution. And you can see a split thickness preparation and the application of the rehydrated mucoderm matrix to the periosteal wound bed. So this is what we did in the past with the free gingival grafts. So let's take a look at the outcome 1 year post-operative. You see we could avoid harvesting of the free gingival graft from the palate. We can see some stable zone of autogenous connective tissue here in this area. Also, this zone is stable, and what we can see for sure that we have a better aesthetic outcome compared to the free gingival graft. The next possible indication for this mucoderm matrix might be thickening of soft tissue around implants. So you can see at the time of opening here the implants, you can see the rehydrated dermis, which this was the first generation. You can see a thickness of about 2 millimeters. You can see that we tried to, with these small flaps here, to cover the area of the mucoderm matrix completely, so there are no regions of the matrix exposed in the healing phase. And you can see post-operative the amount of soft tissue we could gain with this dermal matrix. Also, if you take a look at the appearance of this tissue, it is a nice aesthetic outcome. You can see a dense zone of connective tissue beneath this alveolar mucosa, but it's really a natural aesthetic outcome. So with respect to the gingival recession, so this was one of my first clinical cases which I treated with the mucoderm matrix. You can see at this lower canine no amount of keratinized attached tissue left. You can see here the mucogingival line. And what we did was the preparation of periosteal wound bed, so a split thickness flap, rehydration of the dermis, suturing to the periosteum, coronally positioning of the flap, and this is the healing period. So what we could get 3 months post-operative is this clinical outcome. So what you can see, we have some nice root coverage. At this point of time, we can see some stable dense connective tissue beneath the mucosa here. There's no tensile of the flap anymore here in this area. So this was one of the next cases we treated. You can see this was following orthodontic treatment. Again, here in the area of the first premolar, this is the mucogingival junction, no keratinized tissue left and in this area. So what we did was again split thickness flap, rehydration of the matrix, suturing it to the periosteum with some crossed sutures, positioning the flap to the coronally. And again, what you can see 14 weeks post-operative, you can see first of all that we gained some volume. You can see here that we didn't change the appearance of the soft tissue covering the grafter. However, beneath you have a wide zone of stable, dense connective tissue covered by the alveolar mucosa. The aesthetic appearance is nicer. Also, the volume here, 14 weeks post-operative, is nice and a very natural outcome. So we further tried to improve our cases. Again, in the lower jaw, you can see here on this canine, no connective tissue in this area. What we did here, a tunneling procedure, insertion of the mucoderm matrix into the tunnel, coronally positioning the flap. And you can see here 3 months post-operative compared to the baseline situation. Again, you can see nice volume, what we gained here. Again, what you can see sometimes is this whitish zone, which at an earlier point of healing can be just remnants of the matrix. At a later point of time, it's the remodeled connective tissue. So what you get is really dense connective tissue beneath the covering alveolar mucosa. So sometimes you can see this whitish area, which will mostly disappear with time. So further clinical case, you can see some deep gingival recession at this area, and we tried to get the Zucchelli style. So what we did this oblique incisions. We deepithelized this anatomical papilla, and again we rehydrated the dermal matrix, sutured it to the periosteum, and the surgical created papilla were sutured over the deepithelized anatomical papilla. You can see here the coronally positioning of the flap and the outcome 3 months post-operative. If we take a closer look, you can see here like a small cleft at this area. And beneath again, what you can see, this dense zone of connective tissue, which is present. So what is the cleft and why is it just at this line? So this is the area where the mucoderm matrix was sutured. If we go further after 18 months, you can see without doing anything in this area, without any gingival plastic, this cleft disappeared. And 1.5 years post-operative, again, a nice clinical outcome. You can see beneath dense zone of connective tissue, nice volume, and also nice root coverage. So let's go to some further clinical cases to see, okay, what can we do with this dermal matrix? What shouldn't we do? You can see this was the baseline clinical situation. The free gingival graft was not performed by myself. It was performed by the dentist. So what we did was to prepare an envelope. In this area, we rehydrated the matrix, inserted it into this pouch, positioned the complex to the coronally. You can see I tried to avoid any exposure of the dermal matrix. So this is very important. Try to cover all aspects of the dermis. And so this is the situation 3 months post-operative. You can see here we did small corrections to the 3 gingival grafts, but again, sufficient amount of root coverage. Again, a similar aesthetic appearance. And also the patient, he was very happy. So we avoided grafting autogenous tissue from the palate. The patient was happy with the aesthetic outcome, and there was no need for correction of this clinical case. Another case, again, step by step. So what I try to do, I do the preparation of the root surface before I raise the flap. I do it with a sonic scaler. You see this diamond burr. I clean the root surface. I condition the root surface with EDTA prior to surgery. Although I said it's not an evidence-based approach, however, I think it makes sense to decontaminate this part of the exposed root surface. So I do the tunneling, which is a combination of blunt reflection and then a sharp dissection in this area. I rehydrate the matrix. I pull it inside the tunnel. Like you can see here, the area which is filled with the rehydrated matrix. Here I was a little bit experimenting with the suturing technique, and you can see again 3 months post-operative compared to the baseline clinical situation. Again, nice aesthetic appearance. You can see here beneath my soft tissue zone of dense connective tissue due to this mucoderm matrix. So what you should try to avoid is to leave part of the matrix exposed. So I want to show you this on this clinical case. Again, the same procedure, tunneling. You can see here if sometimes you have not enough of the dermal matrix, take a knife, cut it on both sides so you can get a mesh graft. You can stretch this a little bit more, and you can see that I inserted this into the tunnel, but you can also see here small amount of the graft which was left exposed. So in my personal clinical experience, I can say that the parts which are exposed are probably going to be lost. Not every time, but if we take a look here at the healing period, you can see the healing is nice, but here this is the half millimeter or millimeter which was exposed 10 days post-operative. You can see it here 3 weeks post-operative. Again, it's struggling, but if you take a long-term look at these cases, here 6 months post-operative, you can see within the remodeling process that this area which was exposed, it was lost. Nevertheless, still a sufficient clinical outcome, but you can see also the small amount of soft tissue which was lost because of the exposure in this area. Other case where I tried to use this dermal matrix Also on the lingual aspect, you can see this very deep gingival recession, which is here in the area of the mouth floor. So we know this situation is not amenable to plug control anymore. So it's an area with inflammation all the time. So there is the need to do something in this area. So what we did, we elevated full thickness flap in this area. You see the perforation of the bone. Again, rehydration of the dermal matrix, stabilizing it. So we suture it here at the vestibular side. Coronally positioning of the soft tissue from the lingual, and then we did some stent over here to minimize the retraction of the flap in this area, also to avoid playing with the tongue in this area. However, you can see only suboptimal clinical outcome. We did gain some tissue here in this area, but again, you can see the retraction of the flap. So it's difficult to deal with gingival recession on the lingual side generally, but also for sure with the dermal matrix. Nevertheless, we improved here the clinical situations. So with my last case, I will also want to talk a little bit about possible complications. So this was a case I treated about a year ago. You can see multiple recessions in the lower jaw, also this cervical defect, preparation of a split thickness flap, rehydration of two mucoderm matrices. Again, here I did mesh graft. The two mucoderms are sutured to the periosteum. The knots are on the lingual aspect. I positioned the whole complex to the coronally. You can see here all this is with the mucoderm beneath. And what my final outcome was this. So 3 months post-operative, you can see total disaster. So this is the case which taught me that this is really a technique-sensitive procedure. So what happened in this particular case? It was that in the post-operative healing period, there was some retraction of the flap. Due to the retraction of the flap, most of the parts here of the mucoderm matrix were exposed in the healing period, and subsequently this area was then lost. So you see that the technique, the surgical technique has to be very precise. So we have no forgiving effect as we know this with the autogenous graft. So the same case treated with an autogenous graft, I would also have a retraction of the flap, but probably the outcome would have been different, because some of the exposed parts of the connective tissue would survive. However, with the acellular avascular dermal matrix, you cannot expect revascularization of the exposed part. So you have to be very precise in your surgery. So there's definitely a learning curve, and I like to compare this learning curve with regenerative periodontal therapy, where we started with attachment gains of about 1 millimeter, and then we went up to 2, 3, 4, up to 5 millimeters gain of clinical attachment. Similar are also the results with the acellular dermal matrices. Very promising And when I compare the advantages with the disadvantages, you can see much more advantages than disadvantages. So definitely advantage is that there's no need for tissue harvesting from the palate. Our patients are very thankful for this. We have less postoperative complications, reduced risk during surgery, so we don't have to take care about the arteria palatina, the nerves. We can shorten a little bit our surgery time, and we have tissue which is unlimited with respect to availability, and we have a constant quality of this tissue. Possible disadvantages are tendency to shrink during the remodeling process, so we have to work on this to minimize the tendency to shrink. We have no induction of keratinization, which means that we have no biological information within these matrices, and so we cannot change the appearance of the surface over these grafts. We can say that these techniques are technique sensitive and that these materials cost something, so they are not free. So at this point, I would like to thank you very much for your attention, and I'm happy to take some questions. So, first of all, thank you very much staying with me, and I would like to start taking some questions here from Diego Navas. What about when you use these grafts over implants? Is it possible? Very good questions. I have to admit I have not much experience using the Mucoderm matrix over implants, so with recession coverage on implants. I'm very careful on this because I'm dealing with an avascular surface of the implant, and then I have an avascular acellular dermal matrix which I put over this avascular beta. So in my opinion, that is better. So I would be very careful on using this dermal matrix for recession coverage on dental implants. So next question by Dr. Nguyen. Do you apply periodontal dressing and place patient on Peridex post-operatively? I don't use any periodontal dressings. What I do, for instance, in the case where I grafted the area on the lingual side, I do some stent over this area, but usually I don't use any dressing. I give post-operatively some chlorhexidine, 0.12%, 2 times daily in the morning and in the evening for rinsing, but no periodontal dressing on the area of surgery. So the next question by George Perry. It seems you have a preference what suture material you use, what you prefer, and why. So what you saw in most of the cases was monofilament premilane suture. It was in most of the cases 6-0 or 7-0 suturing material. This is what I like to use mostly, so I don't have any plaque accumulation on this suture. Also, I cannot apply too much tension on a suture like 6-0, so I cannot push my flap into one direction, because the 6-0 suture would disrupt us. So this is also very good to use this kind of suture material. So the next question was by Philip Schönwalder. What about cervical dental fillings? Also a very good question. So what I try to do prior to surgery, that I reduce the amount of the dental filling, so I'm not grafting over the dental filling. I reduce it to the area of the cemento-enamel junction, and then I try to graft till this area. After I remove the dental filling, I try to get nearly smooth root surface for coverage. So the next question, again by Dr. Nguyen. When do you perform the tunneling procedure? Do you utilize split thickness technique? Also a very good questions. So when I started to do this procedure, I did my tunnel in a split thickness manner throughout all the areas. So I started to split the flap as early as possible and did go all the way split thickness. The problem with this approach was that when I got too thin in some areas, that it's very difficult. I had some cases where I did have some perforations due to the splitting when I got too thin. On the other side, the revascularization was good, because there was revascularization from the periosteal side and also from the inner side of the flapper. So with time I changed that I did the first part of the tunnel in a full thickness manner to the area of the mucogingival junction, and over this I go split thickness. So the next question would be, what is from Dr. Raman? What is the most common reason for gingival recession per year in your experience? So I would say what I see on a daily basis is traumatic tooth brushing technique, and the second one, at least in my dental clinic, are the cases following orthodontic therapy. The next question by Dr. Andreas Janigan. How many cases have you roughly treated by now with the Mucodem? How big of learning curve did you personally experience? So as yet I treated about more than 50 cases with the Mucodem with different indications. Most of them were recession coverage procedures. I did pretty much a big learning curve. So first of all, to find the right technique. So today, for sure, I can say that I prefer the tunnel technique as well as the Zucchelli approach. And the tunnel technique, I do the first part in a full thickness approach, and the apical part in a split thickness approach. So I did had a really big learning curve till I find the right surgical technique, also the rehydration protocol as well. So the next question by Dr. Raman, does it also work in grade 3 mobility? That's difficult to answer, so I usually in gingival recession defects you don't have degree 3 mobility. Also mobility is not very positive for your post-operative healing outcomes. So if I have occasion with mobility, I would splint it pre-operatively. So the next question is by Dr. Giovanni Restrepo Osorio. Do you know something about external root reabsorption with technique Emdogain plus connective tissue graft? I have to answer this with no. So I didn't observe anything like external root resorption with the combination of Emdogain and connective tissue graft. Next question is by Dr. Wenson. In case of mucoderm exposure during healing, should we re-entry and manage the site immediately? No, I would allow the tissue to heal, and after healing, I would decide to go for a correction surgery, but I wouldn't go and try to manage the site immediately. The next question by Dr. Osorio, could you tell us if you use some medicines after procedure? So I usually don't give any antibiotics. Very seldom that I give antibiotics in cases where the surgery was for a prolonged period of time or very complicated surgery. But on a regular basis, I don't apply any antibiotics. I give chlorhexidine mouth rinse as usual 2 times a day. I give some ibuprofen as a painkiller, and that's it. So at this point, I see I answered most of the questions. Thank you very much for staying me this evening, and hopefully you enjoyed the lecture. Thank you very much.
Thank you very much, Dr. Kasaj, for sharing your lecture and your insightful information with us. We would also like to thank botiss for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CRP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions for Dr. Kasaj may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Kasaj will be sure to get back to you as soon as possible. Please be sure to visit the botiss educational platform at www.botissacademy.com and keep an eye out for our growing schedule of online courses. Thank you again to all. Take care and goodbye.